Hello, I'm Dr. Keerthana, a fetal medicine specialist working at BirthRight by Rainbow Hospitals. Welcome to our podcast, BirthVibe by BirthRight Hospitals, where we talk about pregnancy and childbirth in simple language. Today we are talking about placenta, which is a very important organ that quietly supports the pregnancy but not talked about enough. To help us understand this better, we are joined by Dr. Himabindu, who is a high risk obstetrician practicing at BirthRight by Rainbow Hospitals. Welcome, Dr. Himabindu. Thank you for joining us.
Thank you, Dr. Keerthana. So, placenta, as you say, is very important in pregnancy and it is not talked about enough. It is generally a temporary organ which develops within the womb and only functions during the pregnancy. It connects the mother to the baby through the cord and transmits nutrition to this. So, as a fetal medicine specialist, you scan the placenta quite a bit. So, can you tell us a little bit more about that?
Along with the baby, in all pregnant ladies, we do evaluate the placenta very carefully. We look for features like the appearance of placenta, the functioning through Doppler examination, the cord attachment, and the location of the placenta, whether it is anterior, posterior, high, or low. And also, we look at the attachment pattern to the uterine muscle. So, we mainly look for conditions like placenta previa or placenta accreta. And once the scan is done, and if there is any mention of placenta previa in the report, the couple starts worrying. So, could you please explain us what this condition is?
That's right. So, in early part of the pregnancy, a lot of placentas can be low. What we mean by this is the placenta is attached to the lower part of the uterus. In most pregnancies, this placenta tends to come up as the pregnancy grows. But if it continues to be in the lower part of the uterus towards the end of the pregnancy, it is called a placenta previa. The reason this is significant is during delivery, the placenta can bleed a little bit more than average at the time. These women will need a cesarean section. Generally, it's a planned cesarean section, and we are prepared for the blood loss, and we generally do our best to try and minimize this.
So, another condition that we hear is placenta accreta, which is very frightening. So, please throw some light on this as well.
Placenta accreta in common terms is called as the adherent placenta. So generally after delivery, once the baby is born, the placenta tends to separate on its own from the wall of the uterus and it delivers. If that doesn't happen and it is more sticky to the wall of the uterus, it's called an adherent placenta. So there are different types of adherent placentas depending on how much it is stuck to the uterus. If it is just stuck a little bit deeper to the wall of the uterus, it's called a placenta accreta. This is the mildest of all. If it is attached a little bit more deeply into the muscle of the uterus, it's called a placenta increta. And if it invades beyond the uterine muscle and goes even outside the uterus and gets attached to other organs, it's called a placenta percreta.
So, of late, we have been seeing more cases of placenta previa and adherent placenta. So, what are the risk factors for this, and why are we seeing them more frequently these days?
So, as we've all seen, the incidence of cesarean sections is going up quite incredibly. And the more the number of cesarean sections, the higher the risk of having an adherent placenta. But we are seeing adherent placentas even after one cesarean section. But other than cesarean, there can be other risk factors, like if the woman has had previous surgery to remove any fibroids, if she's had any endometriosis surgery, even simple surgeries that are done for miscarriages or terminations like DNCs, IVF conceptions, if the placenta is already low lying from the beginning, all of these make the placenta more likely to get stuck to the uterus, which makes it an adherent placenta. So, how would we find this as doctors?
So, when the pregnant lady comes for the scan, like I said, we evaluate the placenta carefully, and the ultrasound gives us clues when there is any attachment abnormalities, like in adherent placenta. So, it gives us clues whether it is abnormally infiltrating into the uterine muscle, or it is extending beyond the uterus or infiltrating into adjacent structures like bladder. And also in placenta previa cases, we do close monitoring to see if the placenta is moving up or not as the gestational age advances. In some cases, especially with the previous history of cesarean section, if the placenta still remains low lying as the gestation advances, we raise a suspicion of placenta accreta or adherent placenta. Yeah. So, do you rely only on ultrasound, or would you need any further imaging modality?
Ultrasounds are generally pretty good in identifying an adherent placenta, but sometimes even after an ultrasound tells us it is adherent, we might go for an MRI. MRI gives us slightly additional information in that what's the actual depth of the placental attachment and whether it's going beyond the uterus. And if it is going beyond the uterus, does it involve attaching to any other organs like the bladder or the bowel? And it's very important for us to know this antenatally so that we can plan her delivery.
Why is the early diagnosis so important in placenta accreta or adherent placenta?
So these conditions, like we discussed, because the placenta is so adherent and it doesn't tend to separate easily after delivery, they tend to bleed quite a lot after delivery. And average blood loss for these conditions is 3 liters plus. So if we diagnose it early enough, we can make necessary preparations. We can counsel the family, the hospital, the doctors, the medical staff, we can all plan and prepare for this blood loss, because these women will need multiple transfusions of blood, various blood products. So preparation will help us in planning for all of this.
So, after you counsel the couple, they must be really scared to listen to all these possible complications. So, are there any technological advances to reduce the complications and planning the management efficiently?
Yeah, absolutely. So these days we have techniques called as uterine artery embolization or internal iliac artery balloons, which we would use generally in these cases where we are anticipating huge blood loss.
So, how do you do this procedure? Could you please explain us about it?
These are procedures which are generally done by specialists called as interventional radiologists. This is not any open surgery. They do it through tiny cuts or access through the groin region, where they put in little tubes which go into the vessels which are providing the blood supply to the uterus. So different techniques are used where we reduce the blood flow to the uterus. And one of the technique is embolization. Another technique is where we use balloons. In balloons, the tubes have basically, like it describes, have got little balloons which are placed in these blood vessels. And just before we start the surgery, the balloons are blown up. So that reduces the blood flow and in turn makes the blood loss much lesser than it normally would have happened. In embolization, tiny particles are again put into these major blood vessels, which also reduces the blood flow to the uterus. The difference is with the balloons, it's only there during the surgery. Once the surgery is done, the balloons are made small again and removed from the woman's body. With embolization, these tiny particles which are used to slow the blood flow to the uterus will be there for a little bit longer. It takes a little bit longer to dissolve, but eventually it has no long-term impact on the woman. The blood flow does resume and the woman feels absolutely normal. And the biggest advantage we have with these techniques is because the blood flow is reduced to the womb, it gives us more time to operate. We don't have to rush because the woman is losing a lot of blood. These cases generally do not bleed as much as they would have if we didn't do this procedure, and they're perfectly safe for the woman, for the baby, and for the outcomes.
So, you have successfully managed cases of adherent placenta in our hospital. So, could you share your experience about it?
So we have done quite a few of these cases at BirthRight, and the reason we are able to do this well is because of our excellent fetal medicine team and radiology teams, where we're able to diagnose these well in advance. We counsel the woman, and then we speak to our interventional radiologists. We prepare them for the procedure, and just before we start our actual cesarean section, they have the interventional radiology procedure with either the embolization or the balloons. Then we start the cesarean, we do our surgical procedure, and the woman goes home well, absolutely well, with a well baby. And we can very proudly say that in BirthRight, we have done several of these cases, none of them requiring any blood transfusion compared to how they would normally have if it's done without using these techniques. And we do this well because we have multidisciplinary team where we plan with our fetal medicine specialists, our radiology specialists, our anesthetists, our blood bank, and our other allied professionals, including our nurses, porters, etc. So it might be a complex condition, but planning is the key, and early detection will help us to plan.
Thank you, Dr. Himabindu, for your insights today. For families listening today, please remember complex pregnancies don't always mean unsafe pregnancies. They just need extra care and can be managed efficiently in good hands. Adherent placenta can sound frightening, but with modern technology, good planning, and proper teamwork, the outcomes today are far better than in the past. Share this video with pregnant women going through high risk pregnancies who you think would be benefited with this information. And follow our BirthVibe channel for more honest and reassuring conversations regarding pregnancy and childbirth. Until next time, take care. Thank you.